Hi, everyone. Wow. Why do I have my glasses
Hi,
on?
everyone.
I'm Lisa.
And I'm Steph.
And together we are
PD
PD Connect.
Thank you so much for joining us today. We've got our guest speaker here, Dr. Ferris. But first, I'll let you know that we're PD Connect. We teach exercise and education for people with Parkinson's virtually wherever you are. So join us anytime and go ahead and do the bio and we'll get this thing started.
Yeah, today we are going to be listening to our interventional therapies for movement disorders by Dr. Margaret Ferris. Dr. Ferris is a fellowship-trained neurologist and clinical assistant professor in the Department of Neurology, a division of the movement disorders at Stanford University. She diagnoses and treats a breadth of movement disorders such as Parkinson's disease and essential tremor. She recognizes the broad effects of these conditions on daily living and aims to develop personalized, comprehensive treatment plans that optimize health and quality of life. Dr. Ferris' research interests focus on access to interventional therapies for movement disorders. She has participated in investigations sponsored by the NIH to evaluate advanced treatments for complications of Parkinson's disease. We're really lucky to have her. We met her several years ago at another conference.
Last year.
Was that already last year?
It
Anyways.
was only last year.
And
But thank you
we're
for
very
being here
impressed
and welcome.
and I hope you enjoy this very much. So take it away, Dr. Ferris.
All right. Can you see that okay?
Yep.
Yes, we do.
All right, so it's nice to meet you all. Thank you for the introduction. I'm delighted to be here. I'm sorry to have changed the timing a little bit, but doctors have families too, and my mom is actually ill, so I'm trying to help manage her care too. So I am going to be talking today about something I'm pretty passionate about. But first, I just want to talk about some of my disclosures. I've been working with a company called Boston Scientific that makes DBS, doing some product testing and to make it work better for patients. Other than that, no other things to disclose. So I'm going to tell you a little bit about interventional therapies for movement disorders, focusing mostly on Parkinson's disease. I'm going to talk about deep brain stimulation. Many of you have probably heard about it, but I like to talk about it when I'm talking about focused ultrasound so that you can compare and contrast them. Talk about why you make a decision to do either of them. And then because it's kind of an exciting time in Parkinson's disease right now, at the end, I'm going to talk about two really new therapies and at least give you a little bit of a touch on them in case you haven't heard about them yet. All right. So when you're talking about interventional therapies for Parkinson's disease, I like to talk about the history. And in the 1950s, we started doing some stereotactic ablative surgery. And that means that we would go into the brain and we basically, with a little cauterizer, we burn part of the brain. And it was noticed that people would do better with this, but obviously that's invasive and it's destructive. And it was a little bit of a dangerous surgery, though it could give people really good benefits for their Parkinson's symptoms. In 1997, deep brain stimulation was approved by the FDA to start looking at research for essential tremor. And then in 2002, it was for Parkinson's disease. In 2016, MRI-guided focused ultrasound was approved, and then it was by the FDA. And then in 2021, it became approved by the CMS, so it would be covered by insurance. There's also out there stereotactic radiosurgery, which you hear mostly in relation to cancer, like Gamma Knife and CyberKnife, which is an option. We use it very rarely in very specific cases, so won't usually hear about that. And then I just wanted to add this in on the end, is there's a brand new subcutaneous levodopa pump that was actually just approved in the fall. And so that should always sort of be considered when we're thinking about these things. So when we talk about these interventional therapies, we're looking at specific parts of the brain. For tremor, we often target something called the thalamus. And for the Parkinson's disease, we target the subthalamic nucleus, or STN, and the GPI, or globus pallidus interna. Now, each of these targets has been shown through years and years of research to treat certain symptoms. In Parkinson's disease, the subthalamic nucleus is good for tremor. It's good for slowness, stiffness, and some gait problems. The GPI, on the other hand, can help to treat dyskinesias. It can help suppress the dyskinesias, and it's very good for dystonia. It also helps with the other symptoms, but maybe not quite as much. So what is deep brain stimulation? Deep brain stimulation requires 2 surgical procedures. Some places will do that at one time, but most do them separate, where we go, one is through the brain, where we drill holes into the skull and put the wires down into the brain. And then the other one is when we put the computer in the chest and connect the two. It's like a pacemaker for the brain. It sends electrical signals in to either replace signals that are missing or to change or modulate inappropriate signals that are happening in the brain. The system is completely inside the body. So you have the leads go down into the brain, and then they're connected to a wire that goes under the scalp and comes down through the neck and then connects to it in the chest. So everything's inside of you. There's nothing sticking out, though you can sometimes see it outside of the skin. We use deep brain stimulation, and I'm putting open loop here. I'll get to that later, what closed loop is, for Parkinson's disease, for essential tremor, and then for some other diseases as well, which are pretty interesting. Dystonia. People who don't have Parkinson's disease can also have dystonia, for Tourette syndrome. And then also we're discovering that it can be used in other things like epilepsy, pain syndromes, and psychiatric diseases. So it's a very exciting technology. What does it look like to get DBS? Well, prior to the procedure, in most places, you'll go meet with a movement disorder neurologist who will do an exam when you are both on your medication and feeling sort of the best you can. And when your medication is off, we often have you hold it for 12, 24, 48 hours so that you're really in sort of your worst state. And we compare those two things and make sure that the medication is having a benefit for you. We will often get cognitive testing. And that's because DBS has been shown in some cases to worsen cognition. And so if you're already having problems with thinking or memory, DBS can sometimes worsen that. Then we'll review the results of the off-on exam and the cognitive testing at something called a review board, where surgeons and neurologists talk to each other about whether someone is a good candidate for this procedure. Then if you get approved, you'll meet with the surgeon and then you'll get scheduled for DBS. On the first day of the surgery, you'd come in early in the morning of the procedure. Most of the time, you don't spend the night. Most places, you'll have your head shaved, though that's changing, and probably about 50-50 now. Some won't shave your head and some will. And you'll have a frame placed on your head. You'll get a brain MRI, and you'll usually be put to sleep. Now, there are 2 types that we do now. Sometimes we have fully asleep procedures, and sometimes we wake people up during the surgery to be able to do testing on them. And that's something to discuss with your neurologist or your neurosurgeon. And then you'll spend the night in the hospital after the procedure is done. Sometimes it'll be 2 nights or 3 nights, but most of the time it's 1 to 2 nights. This is, I used men without very much hair because it's a good example. You can actually see what it looks like on the skin of what the scalp will look like afterwards. There's often a scar. In this case, it's a little bit bigger than there usually is. This might be a little bit more on the right, might be a little bit more what you'd see. And then there's some bumps sort of under the scalp, which you can feel. It almost looks like you're growing horns. But if you still have hair, it usually is very subtle. You can't really see it. You can feel it, but you can't see it. This is what the computer looks like in the chest. It looks a lot like a pacemaker. It's just sort of a square box under it, and you can definitely feel it and see it. So does DBS work? Well, yes, is the short answer. This is a person who has had DBS, and I'm going to just show the video for you real quick. So you can see on the right is someone who has tremor before DBS. And this is actually someone with essential tremor, not Parkinson's disease, but I think it's a really good example. And then you could see on the right side how still his hand is afterwards. So DBS is very good at treating some of the symptoms of Parkinson's disease, the slowness, the stiffness, the tremor, and a lot of the problems with your gait. But things that it does not treat are balance and thinking and memory. Also, sometimes swallowing or speech can sometimes be helped, but not always. So I don't generally tell people that they should expect it to get better. Is it safe? So DBS is a brain surgery. That means anytime you cut through the skin or the scalp, you have a risk of potentially infection. You have a risk of bleeding either around the area or even in the brain. And sometimes that can cause a stroke-like symptom. And anytime you get anesthesia, there's a risk of cardiac and lung problems. Um, as surgeries go, it's a fairly safe one, and we have low sort of risk and low complication rate, but there are real. And if you were the 1 in 1,000 that it happens to, it still really does have an effect on you. There are also risks and side effects from the stimulation of the DBS itself. Some people will notice worsening of balance, or we call it ataxia, where it's a little bit harder to walk. And that's something that we have to keep in mind because a lot of people with Parkinson's disease are already having balance problems. In someone who is already having cognitive problems, sometimes the DBS can worsen that cognition. And that's one of the reasons that we go through and have that cognitive test done. And then sometimes people will have voice changes. Now, the voice changes that come with DBS are a little bit different than the typical Parkinson's voice changes. It can feel sort of tight and strained voice, all the way to actually losing your voice altogether, though that's fairly rare. I'm going to talk a little bit about closed loop deep brain stimulation surgery later. I noted it here. This is in my old lecture thing, but this has actually changed just in the last week. So very exciting. The next thing I want to talk about is focused ultrasound. I've heard that one of you has maybe had this done recently. This is a procedure that is similar to DBS, but different in a few ways, and I'll go. So it involves a helmet that has about 1,000 sources of high frequency ultrasonic waves. When one wave passes through your tissue, it doesn't cause any damage, but when the waves meet, it increases the energy. And when you aim a lot of them at one specific spot, it actually creates heat, and we can sort of burn a small hole in the brain. It uses an MRI and computer focusing algorithms to make sure that you're getting those sort of the beams to cross in the exact spot that you want it to. Unlike DBS, it's an outpatient procedure. It's a 1-day thing. You come in the morning, and then you get to leave that same day. And it's less invasive in that it's incision free, so you don't have to cut through the skin or the skull, and you're not putting any device into the brain. I like to say less invasive rather than non-invasive because we are still causing a permanent change to your brain. You can't undo it, and so it's not completely non-invasive. So what the process looks like for a day of focused ultrasound would be that usually you have to visit with a neurologist or a movement disorder specialist and make sure that you have a correct diagnosis and you would be a candidate. We'd refer you for the focused ultrasound. You have to get a head CT for this, and I'll explain why in a slide or two. You need to meet with the surgeon, and then they schedule you for the focused ultrasound. On the day of the procedure, you come in, you do have to get your head shaved in this one. So unlike DBS, where sometimes people can do it without shaving your head, for this procedure, you have to get your head shaved. You go into an MRI machine and you lie there for a long time. So you're sort of in and out of the MRI machine, but you are stuck lying on a table and can't move for a couple hours. So that is one thing that really can prevent some people from getting it just because they're not able to with their backs. We'll often during the procedure do an exam, do some more with the procedure, do another exam and see how your tremor or whatever symptom we're trying to treat is going. And then you get to go home that day. So that's an exciting part of this. This is what it looks like on the side. You see the MRI in the background with the helmet with the sources of light or with the ultrasonic waves in it. And then there's also a frame that's put on your head, and that's to keep you still so that you don't move during the procedure. On the right, you can actually see one of the little lesions. So with something called the arrow sign, if you look where the arrow is, there's a little white dot. That's how small the lesion is in your brain that we're trying to make. And that's actually a pretty big one. I use one so you can see it, but we often make even smaller lesions than that. The lesion that we're aiming for is usually about 6 millimeters, so about a half a centimeter. Currently approved treatments to use focused ultrasound for. So we use it for essential tremor. We can treat both sides of the brain. For Parkinson's tremor, we can do usually both sides of the brain as well. When we do it for Parkinson's tremor, it really only treats the tremor. It does not treat the slowness, the stiffness, any of the other symptoms of Parkinson's disease. It's really to reduce the tremor. There's another location that we can use called the pallidotomy for Parkinson's disease, which can treat some of the other symptoms like the slowness, the stiffness, but it's only one side of the brain right now. We are unable to do both sides. So it really only makes sense for people when they have very unilateral symptoms. So really their symptoms are only on one side of their body right now. And even then, it's a harder technique to get a good lesion in the pallidum than it is in the thalamus. So I usually don't recommend this for people unless they don't really have another choice. And I'll get into some of the other reasons you might pick one versus the other. There's also going on out there research to do. I mentioned one of those areas called the subthalamic nucleus is what we use for DBS. There are some research going on to treat that as well, but it's not currently approved in the United States. Reasons you might not be a candidate for focused ultrasound would include that you can't get into an MRI. So you have something in your body that's not MRI compatible, or you're very claustrophobic and you wouldn't be able to tolerate it. We generally don't do it on someone if they're pregnant, if they have very severe kidney stones, if they have uncontrolled other medical issues that would make it unsafe for them to be in the MRI and sort of fixed there for a while, like alcohol, severe alcohol use, making a risk for seizures or very high blood pressure or heart problems that you're at risk for having a heart attack. Now, originally, we also wouldn't do the procedure in people who had bleeding risk if they were on anticoagulation or aspirin or another antiplatelet, but that's actually changed recently. And so now we can actually do this procedure even if you need to be on your anticoagulation or your antiplatelet drug, which is very exciting. But the biggest thing I think that keeps people from getting it is the ability to lie flat for a couple hours, because obviously people who are a little bit older have more back problems, and lying flat can hurt that. At Stanford, we can sort of use pillows to make you more comfortable, and we have a massage therapist who sits there and helps you to stay comfortable. But that's not true everywhere you go. The last thing is something called the skull density ratio. And this is why we need the CT scan. So on the left, you see someone with a low skull density ratio. And you can see that the bone, this is a sort of an X-ray of the bone through the head, that the bone looks spongy and there's dark stuff in it. And then on the right, where the bone looks very white and dense, when the bone is spongy, which means it's thick and doesn't have a lot of density to it, that means that the ultrasonic waves can get caught in the skull and bounce around. It means we have to use more energy and it causes more side effects. So it's very uncomfortable. And if your skull density is low enough, we can't do the procedure because it would be so uncomfortable for a patient. If you have a higher skull density ratio, you'll be fine. So does it work? Well, this is a patient with essential tremor. On the left was their spirals that we have them do before the treatment, and on the right is after the treatment. And you can see that there's significant improvement in tremor from the focus. This is another example. But how about for Parkinson's disease, not for essential tremor? This is a lot of data. I don't expect you can pause it if you want to look at the data, if you're sort of a data-driven person. I put this on here just so that I can go over basically the population that the research studies were done in. It was mostly men, a higher percentage of men, so we might not have quite of an idea of whether it works on women as well. The skull density ratio is generally around 0.5. So if you're lower than that, you may have more side effects. And then when you look at the benefits, we can see that at 3 months, people who had the procedure done versus the sham were significantly
put you on speaker.
comparatively. And that lasted for 6 and 12 months as well. Now, when we talk about what is a response, well, the graph lower than this is if it's gray, there was no change. If there was sort of a dark blue, it means that there was less dyskinesias and less Parkinson's symptoms. And then the other ones are either one or the other. So you can see that in the sham procedure, most people didn't have any benefit. And with the focused ultrasound, there was about 70% of people had improvement in either one or both of the criteria. So either dyskinesias improved or the MDS-UPDRS, which is our measurement of slowness, stiffness, and tremor, improved. So I mentioned that the STN is that experimental one, also seems to be showing some benefit. The risk with the STN when we do lesion studies is that it can increase dyskinesias when we lesion it. So we're working out the details of that right now. This is, however, the exciting thing coming up. So right now, this is being reviewed by the FDA. It's a new target called the PTT, or the pallidothalamic tract. And it is potentially going to help with tremor, rigidity, slowness, and stiffness. Right now, we've finished the study, so all the patients have had it done on one side or both sides. And right now, the FDA is reviewing it to see whether it will be approved. All right. So is the procedure safe? Well, during the procedure, these are temporary side effects. People may experience sort of a heat or pressure, vertigo, a sensation of movement, and it's often a funny, like a experience of your feet being flipped over your head, nausea or vomiting kind of going along with that vertigo, tingling, some back pain, anxiety. The most common thing people complain about is headache, and I would say almost every patient will get a little bit of a headache during the procedure. But those all go away. So the thing that's the most important to talk about is the adverse events after the procedure. What might you get stuck with? The most common are going to be vocal changes like slurring of speech, swallowing problems, or balance. And the reason that you have these is just because where we're lesioning are near other parts of the brain that are responsible for those things. We've also had people that had problems with tingling or numbness in their hands, in the hand that we're trying to treat, or in their feet, and sometimes weakness, though the weakness is very rare. They've also reported problems with taste and problems with hearing afterwards, though we think that's probably not very related to that. Now, the percentage of people that have these side effects are generally low. Almost everyone will have a little bit of a change in their balance after the procedure, but how long that lasts is very patient dependent. Most people, the balance will return at least close to normal within a month or two. Okay. This is a report of, if you want to come back, I'm not going to spend too much time on it, but all the side effects that were reported when we did the GPI treatment here. So there was some reflex changes, some sensory changes, as I said, some loss of taste, dizziness, some balance problems, fatigue, headache, things like that. And I'm not going to spend too much time, but these are some of the other side effects that you can have for the other location. And the big thing that's different with this is that there's just extra movements, which don't usually happen, the dyskinesias, which don't usually happen with the other location. So why do people choose one versus the other? This is an essential tremor, so it doesn't apply very much to Parkinson's disease, but I think it brings up a good point, which is that in general, people who choose DBS tend to be on the younger age. Because DBS has been around a long time, we know that it'll last a long time and it is a proven therapy. And also younger people tend to be more medically stable and able to tolerate DBS, whereas focused ultrasound is safe for older people and doesn't have as much of the sort of surgical complications. Depending on the group and where you are, most of the time our cutoff for thinking the surgery is fine at an age younger than that is about 80. And around 80, people start to become a little bit more frail, have a little bit more medical comorbidities that make us question whether DBS is correct. However, every patient has sort of a different age, like body age compared to year age. And so if you're a healthy 84-year-old, we would still very much consider DBS on you. And if you're an unhealthy 76-year-old, we might not. All right, so this is just talking about why people might choose one versus the other. With focused ultrasound, a lot of it has to do with just people not being aware that it's out there. And so that's one of the reasons I come and talk to people about it, so that everyone's aware of the different options. I talked about this already. This is the palatothalamic tract test. I'm not sure when or if it's going to be approved, but I'm crossing my fingers that it might be approved in the next year or two. And in that case, focused ultrasound really might become a better choice for Parkinson's disease. All right, so I promised at the beginning that I was going to talk about this. So adaptive DBS was actually just approved on Wednesday. So we're now 5 days into this brand new thing. Adaptive DBS actually has a sensor in the brain, and it can read the brain waves that are happening at any time and change how much electrical signal it's giving to the brain based on the waves that it's detecting. This is new. It requires less sort of input from the doctor at any one time. And it's very exciting because we think it mimics the more physiological state. So that's very exciting, brand new. If anyone is considering DBS or maybe was even waiting for this to come out, it is now officially out. So it's something to bring up with your neurologist, whether adaptive DBS might be a good thing for you. So this is kind of the big slide that most people are most interested in, which is why would I choose one versus the other? And I actually have added Vyalev on here. Vyalev is the new subcutaneous levodopa pump. And the reason I put it here is that by the time people are considering an interventional therapy for their Parkinson's disease, they're usually having some kind of side effect from the medication or dose fluctuations. They're having lots of off and on time, sort of ups and downs, or their medications just aren't working as well for them. So these are sort of 3 alternatives you can think about. So I'm going to talk about Vyalev. This is the new subcutaneous pump. It's like an insulin pump where you wear a little machine with you and you have a tube that goes to your belly. It's not the one you may have heard of before, the Duopa, where you had to have a surgery and put a tube into your stomach. This is just goes on your skin. It's a little patch that you go like boop, and it pushes a tiny, tiny little catheter into the skin. It's non-surgical. There's no surgery required, which means there's a much lower risk of getting surgical infections, things like that. We know that the short-term outcomes have been very good. People have been very happy with this. We don't have any long-term outcomes because it was just approved recently. It's just using levodopa like any other levodopa. It's just instead of taking it orally, it's going through your skin and it's going constantly. So you don't have those ups and downs like the taking the pills. You can turn it off and you can turn it back on. There is a slight infection risk around the skin area where you put the patch on. So that's the one kind of thing that goes with it, and it can cause sort of bumps in that area. And there's some patient criteria is reasonably strict right now just because it's brand new. I expect over time that patient criteria will drop. DBS, on the other hand, it's a surgery. It's invasive. We're cutting into your brain. But we know that it's very durable. We have 25 years of data to show that it works well. You can use it on both sides of the brain at the same time. You can change it, you can turn it up, you can turn it down, and you can change it if you're having side effects or symptom changes. You can turn it off. But there's a risk of bleeding and infection. You have to have multiple surgeries. You have to interact with doctors a lot to have it programmed and continually modified. We have reasonably strict patient criteria. And then there's focused ultrasound. It's a surgical procedure, but it's significantly less invasive. We don't have nearly as long data, but it's probably a little bit less durable than the DBS is. Right now for Parkinson's disease, if you want to treat the slowness or the stiffness, we can only treat one side right now. Knock on wood, the next the trial will be approved soon for bilateral. You can't change it. It's a one and done. So once we've made a lesion, it's done and we can't fix it and we can't do any more. And so with that, if there are side effects from them, they can be permanent. But it's a lower bleeding risk. There's no infection risk. It's a one-time procedure. The patient criteria is a little bit less strict, and you don't have to see a doctor nearly as much. I'm going to skip this. It's a lovely video from the Stanford lab, but I'm running out of time. I want to give a couple minutes if anyone has any questions. Also, we are at Stanford recruiting for a number of clinical things, mostly observational trials. So if anyone's interested, you can find our website about what we're recruiting for right now. All right, sorry to have rushed through that a little bit, but I want to give some questions if anyone has any.
Yes, thank you.
There was one question in the chat there, and that first question was, for any of the procedures you discussed, are they ever repeated if a patient doesn't respond with a response after retreatment?
Okay. So DBS, it's not that well, sort of. So DBS, if there's a problem and we determine that like the lead location isn't ideal, sometimes people will go in and move the lead. It does require another brain surgery, so that's a pretty intense thing to do, but it does happen to patients. I'd probably say like 1 in 100 patients at Stanford has to have their lead sort of removed and replaced into a different spot. With focused ultrasound, the evidence is not good one way or another right now. So sometimes if we don't see a lesion after the procedure was performed, and there's no lesion and there's no benefit, we will sometimes redo it. As long as there wasn't a reason why. So sometimes the reason there was no lesion is because those side effects during the procedure were so bad that just the technique of it in the brain isn't going to work for your head and your brain. In most cases, we do not redo focused ultrasound because if there's a lesion there, then it's there and it just didn't work. But there are cases, a significant number of cases of people who've got focused ultrasound we then put DBS into because the focused ultrasound was either not effective enough or not effective at all.
There's another question regarding the Vyalev. Do patients get dyskinesia?
So I will say Vyalev is new enough that I actually only have one patient on it right now, and she was not someone who was getting dyskinesias already. The answer is probably yes. It is still levodopa, so you're still susceptible to dyskinesias. But we think the chances are lower and you're less likely to have them quite as badly because the idea is that you're taking, rather than giving all of the medication in kind of bursts, we are giving medication spread out over 24 hours so it's more even and you don't go those ups and downs. And most people get dyskinesias sort of in the ups and downs or at those peak doses. So while the data is not 100% clear, we do think it will probably improve dyskinesias for many people. I see the next one is the only reason that MRI is required for the ultrasound targeting. I'm not sure what the question was, I don't quite understand it, but MRI is absolutely required for ultrasound targeting. You cannot do it if you don't have MRI. That's in part like of the procedure itself. So,
Can an existing DBS system convert to a variable system?
Like, I think what they mean is, can they convert to the adaptive closed
so
system?
it depends. If you have Medtronic DBS and you've had it put in the last 2 or 3 years, there's a chance that you can switch to the adaptive. If you have a Boston Scientific one, no, you cannot. Right now, I will say Boston Scientific is also working on trying to make an adaptive system, but they're far out. So it probably won't be in the next couple of years, but maybe in 5 years. Is Vialev covered by insurance? So right now, Vialev is so new. They are promising if you have private insurance, that Vialev will be covered. Medicare has not approved it yet, so it's very iffy. We have had one person with Medicare get it approved, but it's a little bit more challenging with Medicare. The government always sort of takes a little bit longer to approve these sorts of treatments. Question about treatment for Parkinson's using stem cells. Right now, there is no approved treatment, but there are a lot of clinical trials coming up. If you are interested in potentially being part of a clinical trial for stem cell therapy, a number of the places around here, Stanford, and I think UCSF is also considering being part of those trials. So I would check with both of those places in about 6 to 9 months and see if they're recruiting at that time. I know we will be. Maybe starting like July or August. Vialev may help with nausea. We don't know. My one patient that is on it is actually because she cannot tolerate oral levodopa. If you are otherwise, you have to show that you're getting good response to the medication before you can go on the Vialev. So if you are getting good response but have persistent nausea, then it might be something worth trying. Oh, what about the Abbott? Sorry, I don't talk as much about Abbott because it's not as common, but Abbott DBS can't be converted to adaptive right now either. Transdermal formulation of levodopa ever been explored, like a patch? People are working on it. It hasn't been approved yet, but people are trying to do something like that. Adaptive DBS, if you have the right machine, you can get the adaptive DBS, but you have to have a Medtronic with the correct kind of lead, which has a sensor on it. But even if it's just one side, yes, you could get adaptive DBS. How is the pump different from the patch? So if you are using a patch right now for Parkinson's disease, it is not carbidopa levodopa. It's a different kind of medication. It's probably like rotigotine, which is a dopamine agonist. And so levodopa, the pump is only levodopa right now. So it's 2 different medications. And then what is my opinion about whether levodopa is effective with tremors? So some people, levodopa can be effective for it, but not everyone. And there are many other medications that can be used that can sometimes be more effective for tremors, including dopamine agonists, including anticholinergics like Artane. And so there are usually other things that can be tried as well, though DBS can also be effective for that. So the effects of benefits of adaptive versus constant DBS, it is so new. There is one paper out that summarizes it, but the paper actually just shows that they're equivalent. It doesn't show any specific benefit yet for adaptive versus regular DBS. So right now the data is sort of still out. It's just as good as, but hasn't been shown to be superior to as of right now. All right. I do apologize. I have to run. I am happy to come back and answer more questions at another time. It was very nice to meet you all. I hope this was helpful. And if it was, just let me know. Or if you have more questions, I'm happy to answer them by email afterwards too. Maybe if you can send them to the team and they'll send them to me. All right.
Absolutely, we will do. Thank you
Thank
so
you, Dr.
much.
Ferris.
Thank you. Have a wonderful day.
Thank you, you too. For those of you who you're here, we are PD Connect. If you came in a little bit late, you can check us out at
Yeah, wow, I mean, we talk about DBS a lot and we always
Oh,
want
sure.
to talk about what the new interventions are. And, we went through that kind of fast and there were a lot of technical
a lot
things
of
in
things
there.
to be said.
It's like we need time to process this, so that's why we do put these recordings up there. There was that one slide where she compares the 3 different things, and I think, if everyone really kind of wants to take a look at those things, let's not simplify what that slide means and really absorb what each thing means.
Sure. And not to mention, if you are considering one of these procedures, you certainly need to check in with your physicians and see what works best for you to see if
Yeah.
you even qualify
Right.
for
And
these
we do
procedures.
these interviews for educational purposes. We're not recommending any of this for anyone.
Right.
We're not in a position to do that.
But we want you to have the information
Yeah.
to bring to your doctors
Yeah.
and to your families and ask questions.
Yeah.
So if you do have questions, please reach out to us. By the way, we teach exercise and education for people with Parkinson's. You can check us out at www.pd-connect.org.
Yeah.
We teach,
I'll tell you, no side effects.
yeah, our exercise, no side effects.
Too much
Except for the
laughing.
giggles.
Yeah, maybe
Yeah,
too
the
much giggles.
That's true. And maybe you're going to need a little bit more water.
And
Absolutely.
yeah,
But what we do is we teach
Water.
exercise online and in person. So come check us out. We'd love for you to join our classes and watch Lisa drink water on YouTube. So if you have any other questions, please email us or subscribe to our newsletter that has all of our schedules in there. And check us out on YouTube where this video is. We've got tons of videos up for free for exercise and for education. Let us know if you have questions.
yeah,
I'd
this
love to hear
is
from you.
our first Monday of the month speaker series. So
Well, it was.
It was, yeah.
Yeah.
But again,
Yes.
going back to that slide though, I think that one of the
There's a lot of
there
slides.
were a lot of slides. There were definitely a lot of slides, but I think, knowing that something has been around for 25 years and knowing that things have been perfected and the science has been perfected and we know what the outcomes are and we know the pros and cons and how things have done 20 plus years after is always helpful to know. Because anytime you're going in with something new, you just, it's wonderful that there are options, but it's just.
We want you to be as educated as you can.
Exactly.
Right. Well, thank you all for joining us, and we will see you next time.
Yeah, we'll see you.
Yeah, we really appreciate
tomorrow.
your support, and we look forward to seeing you in class.